Hello everyone, my name is Rachel Notareschi. I am a nurse practitioner student from Auburn University. Today I'm going to be talking to you all about hypertension medication non-adherence in the elderly and why it is such an important topic. So to give you all some background information on why this is an important topic in healthcare, persons age 65 years or older are estimated to double from 52 million to 95 million in the United States. Hypertension is one of the top medical issues worldwide, and the effects of hypertension, specifically within the elderly population, result in very poor quality of life. 9.4 million deaths a year alone are due to heart disease and stroke worldwide. So hypertension is actually the second leading cause of death globally. It increases the risk for cardiovascular disease, cerebrovascular disease, renal disease, and can lead to premature mortality as well. Elderly persons make up about 2/3 of the total hypertensive patient population. So in primary care clinics, in hospitals, everywhere, people are seeing more elderly patients, and many of these elderly patients are suffering from hypertension, from uncontrolled hypertension, and they have a lot of other comorbidities that make them specifically sensitive to having uncontrolled hypertension. And something as simple or as controllable as medication adherence can make such a huge impact on their quality of life and improvement of their health. So based off of the Iowa EBP model, a PICO question was formed. This question is, in primary care patients 65 years of age or older treated for hypertension, what evidence-based interventions used by primary care providers versus the current standard of care would improve medication adherence and achieve therapeutic blood pressure control among this population? So the target population is elderly patients age 65 years or older. These patients have to have been diagnosed with hypertension for at least 6 months and currently taking one or more hypertensive medication. So during the summary of evidence, looking through all of the different articles, using PubMed, using the Cochrane database of systematic reviews, four main things that most articles addressed and really talked about was the non-adherence rates, the health beliefs and healthcare providers' influence, and then the home interventions and the pharmacist and provider education. So the non-adherence rates within this population, the lack of compliance to the antihypertensive medications is believed to contribute to over 125,000 deaths per year. Proper adherence to the medications can reduce the risk of stroke from 35 to 40% and highly reduce the risk of cardiovascular events and even lessen the onset of heart failure. So some of the reasons that many elderly patients have for the low adherence rates, it can be associated with the fact that they have long-term drug therapy. They are taking these drugs for life, usually, unless they are changing their lifestyles and stuff like that. And sometimes that doesn't even control their blood pressure well enough. And some of these blood pressure medicines, they have bad side effects and side effects that really affect elderly patients even more. So they'll stop taking it from the adverse drug reactions. Also, complicated drug regimens and the overall lack of education have also been proven to show for reasons of non-adherence among the elderly population. Some other factors also included the patient's occupation, whether or not they were retired or still working, the duration of the hypertension diagnosis. So if these patients have been diagnosed for a shorter amount of time, they tended to have low adherence rates. And this was mostly due to the fact that patients that were diagnosed over a longer period, they obviously would have more experience and education on the matter. So it would also affect the number of drugs they're currently taking. So if they're only taking 1 or 2 hypertensive medications versus 3 or 4, it's a lot easier for them to comply to those regimens. So the healthcare beliefs and healthcare provider influence, the information motivational behavior model was used throughout quite a few level 2 evidence articles, and they suggested that there was 3 factors that maintain healthy behaviors that provide these individuals with accurate information that could be easily translated and easily accessed, so such as handouts, talking to them face to face so they could understand this information, and then giving them that personal and social motivation to actually act on the information, and providing them with the skills to carry out the healthy behavior successfully. So it would be really easy to tell these patients, you need to be checking your blood pressure at home with a home blood pressure cuff, and then just leave it at that, and they have no education on how actually to use a home blood pressure monitor, let alone interpret the readings to know, okay, I don't even know if this is high or low. I don't know what my blood pressure goal is. So the survey of elderly patients in the United States, one of the studies showed that the patient-physician relationship had a huge influence on the elderly patient's medication beliefs, and could improve the overall adherence of their hypertensive medications. So the home interventions that showed a lot of success was the use of home blood pressure monitors and the use of home reminders. Interventions delivered at home reduced money, time, cost, and created an ease of access for a lot of these patients. Some of these patients, whether it was due to physical immobility or cognitive immobilities, it worked a lot better for them if they were able to do these things at home and not have to go out. So extensive instructions created reports of improved blood pressure control and increased the confidence in the dosage of their medications. Some patients would feel like they were taking too many medications or they were taking too much, but once they were really educated on it and had a better understanding of their disease and the medications, they tended to have more faith in it. So the reduction of systolic blood pressure was seen significantly when patients were given home blood pressure monitors that also had the capacity to store their readings. So this made it easier for them to look back and see what their morning blood pressure was, what their blood pressure was for the past week when they go to their follow-up appointments. Adherence rates increased by 22.6% in the intervention group that received the education on the home blood pressure monitors and received home reminders weekly. Pharmacist and provider education, motivational interviewing and education, pharmacy-based medicine review, pharmacy-initiated dose administration aids, and things like refill reminders resulted in increased adherence rates in the elderly population. 2 studies that involved pharmacist-led interventions resulted in increased adherence rates in the intervention group and had an overall increase of knowledge about hypertension as a disease and showed an improvement in systolic blood pressure. So these are the different articles that I use to look at for the critical review of evidence. They range from a level 1 to a level 5. They involved 2 systematic reviews, quite a few level 2 randomized control trials, and then 2 case surveys as well. So based on those articles, I came up with 3 different recommendations There are 2 grade A recommendations and 1 grade B recommendation. The first grade A is routine hypertension. Health education should be provided to all elderly patients prescribed hypertensive medications. The health education should be modified to address specific patient concerns and reasons for non-compliance. The medication adherence scale may be utilized by the providers to understand at what stage or what point of non-compliance their patients are at. And this health education should be done by the pharmacist and the patient's general practitioner or physician. The second grade A recommendation is patients should have education that can be given at home. This education should include the use of home blood pressure monitoring, healthy lifestyle practices, and weekly medication reminders. Grade B has regular follow-up visits that last 15 minutes. The follow-up appointments need to include the assessment of patients' beliefs surrounding medication use and answering specific questions of concern regarding adherence to their medications. So during my setting assessment, I used a primary care health clinic. This specific clinic, they see 50 patients per week. On average, about 30% are age 65 years or older. Of those patients, 50% are currently taking hypertensive medications, and only 30 are getting adequate control of their blood pressure. So the current ways of measuring adherence within the clinic are measuring their systolic and diastolic blood pressures every 6 months at their follow-up appointments. The patient reports of compliance, so whether or not they're coming in and saying, yes, I've been taking my medication as I should, no, I haven't, and things of that. And then also pill counting, seeing how many pills are left in their pill bottles from the previous prescription. So during the staff interview, it revealed some reasons that many patients would say that they were not taking their medications, their hypertensive medications, as they should be. And the 2 biggest reasons were negative side effects. So if they had things like feeling lightheaded or dizzy, or they were having problems, erectile problems, they would stop taking their medications. And another reason was they would just stop taking them because they said they didn't feel bad anymore. And obviously then after a while they'd start feeling bad again. So some gaps in care, the providers often experienced or felt like they experienced a lack of time to properly educate these patients. That during high influx seasons like the flu season, they just did not have enough staff and they did not have the time to educate all of the patients. So the patient outcome data that was found during the setting assessment, the team leader, myself, made a Likert scale survey that consisted of 14 questions. It ranged from 1 through 6. 1 was strongly disagree, 6 was being strongly agree. So the amount of education and knowledge of blood pressure medicine, the mean score was 2.3 among patients that completed the survey, meaning that it resulted in inadequate amount of knowledge. The non-compliance due to negative side effects resulted in a mean score of 5.3, meaning that most patients did feel like the negative side effects impacted their adherence to their medications. All patients expressed a need and interest for home blood pressure monitors. So during the setting assessment, 3 patients over the age of 65 were given the surveys. So this is obviously a very small sample survey that would have to be much more widely done for the results to be inconclusive and give us a little bit more information. The implementation and evaluation plan, there would be 3 different phases for the clinic. The first phase would involve the team leader to have access to the computers and the patients and collect the list of patients who meet the criteria for the mentioned target population. The team leader would contact patients at the clinical site or via phone calls and assess the baseline knowledge using the Likert questionnaire and the medication adherence scale to see where they're at as far as adherence with their medications. And then a collection of all baseline systolic blood pressures and diastolic blood pressures. After collecting all the data, it would move into the second phase, which would be the educational focus. Patients would be provided with written handouts on the specific medications that they're taking, overall just information about hypertension and it as a disease, the use of home blood pressure monitors, giving them a range of what to look out for what's normal and for what's not normal, what time to take their blood pressure, and what readings they might have to contact their physician about. And then ways to address any concerns that they're specifically having to adherence, whether that is in access to their medication, whether it's setting reminders, if it is not believing they need to take their medications, or if it is any negative side effects, seeing if something can be worked out to address those side effects. The U.S. Food and Drug Administration and the CDC website have handouts that would be utilized. These are great handouts that break down each aspect of it. They tell you all about different medications, antihypertensive medications. They give great charts and great examples for the home blood pressure monitors. And then the scheduled follow-up appointments would be moved to every 3 months for patients, so more frequently. The appointments, again, would be lasting 15 minutes or longer, focusing on the list of set patient questions and addressing adherence concerns. These set patient questions would kind of be set before their appointment between the provider and them. It could be set from the previous appointment or made over the phone. Then hypertension education and the home blood pressure use again. So the post-intervention data collection would be the third phase, and these patients would again be provided the same 2 questionnaires, the Likert scale questionnaire with 14 questions, and then the medication adherence scale questionnaire. And there would be a reassessment of the patient's systolic and diastolic blood pressure post-intervention. These results would then be entered into the SPSS software. The outcome and measures and the tools. So the Likert scale questionnaire and the medication adherence scale would be 2 tools that we would be utilizing to measure outcomes. And then there would be a conduction of closing interview with open-ended questions focusing on the project's usefulness, effectiveness, and practicability at the clinic. And the input of data of the systolic blood pressure and the diastolic blood pressure and the calculated mean score of the questionnaires to evaluate the effectiveness will be put into the SPSS software. So the stakeholder evaluation form, these are some questions the stakeholder might have for evaluation of the project and plan. So the exact timeline, what is the timeline? Ideally, this would range over a 12-month period because evidence-based practice had shown that interventions that lasted over a 12-month period were more successful and resonated with patients and stuck with them much longer. How much would this cost the clinic? For the handouts, the monthly cost of the handouts, depending on how many patients they would see that meet the criteria and how many they would see on average each week, would vary on this cost a little bit, but on average it would be about $20 a month to provide all these patients with handouts. Who all is expected to be involved? So the nurse practitioner, the nurse, the technician, The scheduling person at the clinic would have to be involved as well. The team leader, and ideally, if the team leader could reach out to some of the patient pharmacists and see if they would be willing to also be involved, that would be a great tool as well. What are some barriers that could stop this project from working? So if patients aren't willing to partake in it, that would obviously stop it and inhibit some of it. Another thing that might be a barrier is the time for the clinic. It does take some time to educate these patients, and some scheduling conflicts for times when they're more busy, such as the flu season, could become an issue, and then just overall staffing might be an issue as well. How long until improvements are expected? Many of the studies and articles showed improvements at the 6-week mark when they would measure adherence scores and improvement in knowledge. So usually around the 6-week period is where you would see some improvements. How will success be measured? The blood pressures would be entered into the SPSS software, and that would see if therapeutic blood pressure control was working, and then as well as seeing if the patient's experience in education and adherence rates went up at the end of the project. And what is needed exactly from the clinic to implement the project? Specifically, what would be needed for the clinic would just be the openness of allowing the team leader to collect data, to speak with patients, to hand out these flyers or handouts from the CDC and U.S. Food Drug Administration websites, and then just spending the time working on scheduling conflicts and things of that nature. So that would be the evaluation form. If you all have any questions, please feel free to comment down below and just let me know what your questions about the project may be or anything that could be improved. So thank you very much. These are the references.